So when we're looking at the cardiovascular system, hopefully you can cast your minds back to anatomy and physiology when you covered this content, and recall that the cardiovascular system essentially comprises of the heart and the blood vessels. So we're talking veins, arteries, capillaries. And the structures of the heart, so the atria, the ventricles and the valves, they all work together to pump freshly oxygenated blood, nutrients, hormones through the arteries and the capillaries to the tissues. The veins then will then carry that deoxygenated blood and other metabolic sort of waste products back from the tissues to the heart. Our heart then, it consists of 4 chambers. So we've got the 2 atria and the 2 ventricles. And we think of the heart as the engine or the pump, right? The arteries, they will then send blood from the heart to the lungs and the body. And the veins, their role is to basically return blood from the lungs and the body to the heart. The capillaries, they act as this sort of interface between the arteries and the veins, and they facilitate exchange of basically gas, nutrients, and other substances. So that's where that all takes place, through those capillaries. So our cardiovascular system can be divided structurally into the heart and the surrounding vasculature. So we're talking, when we talk about the surrounding vasculature, we're talking about the surrounding big vessels around that heart that are fairly central to that heart. And so these comprise of our arteries, some fairly major arteries and veins. And then our peripheral vascular system, so that talks about arteries, veins and capillaries of limbs. So we always refer to limbs as peripheries, or like, so I always think peripheries like being far out, so limbs, arms, legs. And both of these, within these, this cardiovascular system, our heart and surrounding vasculature and the peripheral vascular system, both of these things are supported by lymphatics. So we'll go through this a little bit later in the content, but lymphatics essentially refers to another system of vessels, ducts and nodes, and their role is to retrieve excess fluid that's escaped from the capillaries into the tissues. So it brings them back into that vessels within the bloodstream. So that you don't really, like, if you don't have that lymphatic system in place, this is when you can get really, you'll see it in the community, you can have people with really, really sort of swollen or edematous limbs, and that's because their lymphatic system isn't working quite correctly, and there's some reasons for that, and we'll go into that. So when we're looking at our heart location, I always think of a upside down triangle, okay? So the base of that upside down triangle is at the top. So basically there where that arrow is. So it's basically formed mainly by the left atria and some of the posterior right atria. And the point, so think of the tip of the triangle, we refer to that as the apex. So base is at the top up here, and our apex is down the bottom of the heart. So our heart will sit in this region of the chest, which we refer to as the precordium. And the precordium is this region that basically contains our heart, the surrounding great vessels. So think aorta, pulmonary veins, pulmonary arteries, the superior and inferior vena cava. So our heart and our great vessels are located between the lungs in the sort of the middle third of our thorax. And our heart, our heart will, I'm having a malfunction with this. Our heart will extend from our second intercostal space to our fifth intercostal space. And you can sort of see that from those arrows there. So that's where our second intercostal space is, and this is where our fifth intercostal space is. And our heart, I don't know, most people always think that the heart just sits on that left sort of side of your chest, but it actually extends across into your right sternal border, okay? So it's quite, the heart is quite a big sort of muscle there. So to sort of know where that's located, you can palpate it yourself, and you can sort of palpate on yourself where the heart actually is. So if you're to locate your clavicle, there's two ways you can do it. So you can locate your clavicle, which is that nice sort of long, strong bone right here. If you if you palpate your own and on the right side of your chest, at the right border of your sternum there, if you move just directly one position below that bony sort of prominence of your clavicle, you're going to feel a gap or a space, okay? So that's going to be your first intercostal space. If you then roll your fingers over the top of that gap, you're going to go move across a rib essentially. Keep rolling down until you get to the next space, and that's going to be your second intercostal space. And that, right next to your sternal border, that's going to be where the base of your heart also hits, okay? The other method that you could do to locate that second intercostal space is you actually find your little sternal notch. So when I always go to the top of where my sternum is and go down, and you'll feel this rise in your sternum, we call it the angle of Louis. When you go directly then to the right of that, it will take you straight into a gap there now, which is also now your second intercostal space. But either way, as long as you're in that second intercostal space right beside the right of the sternal border, that is basically where the base of your heart will be sitting, okay? We'll be practicing that in the labs because you need to basically find that little landmark so that you can hear specifically to some heart sounds. So when we are looking at our heart structure, we have got our 4 chambers, as I said before. We've got the 2 atria. Have I got these here? Yep. And our 2 ventricles, which are down there. So the atria and the ventricles, they will work together at the same time. So essentially, like, both the atria will relax, or that means if a structure there within the heart is relaxed, it usually means it's filling. So if the atria are relaxed, they will do that at the same time. When they contract or eject, they will do that at the same time. And both ventricles will also relax or fill, and then they both will contract or eject at the same time. And this is then directly related to our cardiac cycle. So this is where you then start seeing the words like systole and diastole appear. And so we'll go into that a little bit more here now. So within our cardiac cycle, the sounds that you guys are going to be really wanting to listen to within your cardiovascular assessment is this S1 and S2 sound. But essentially, diastole, I always think of diastole as just meaning that's relaxing, okay? So diastole is will occur when the ventricles are relaxed. At the beginning of diastole, you'll see passive filling of these relaxed ventricles, and that's basically occurring from blood that's coming down through also a relaxed atria. At the end of diastole, you'll see this final filling of the relaxed ventricles due to the blood that's been contracted down from the atria, okay? Then when we move into systole, or ejection or contraction, at the beginning of systole and at the end of diastole, so our mitral and our tricuspid valves will swing shut. So they're located between our atrium and our ventricles, right? So they will swing shut after the atria has contracted. The ventricles will then contract, pushing that blood to the aorta and the pulmonary artery. And then at the end of systole, those pulmonic and the aortic valves, they will also then swing shut, and that's when you're going to hear that also the S2 heart sound. So when those mitral and the tricuspid valves swing shut, so between the atrium and the ventricles, we call that the S1 heart sound, okay? And that's going to be that first sound that you hear out of that lub-dub, lub-dub. That's the lub, okay? When the ventricles contract, however, though, and they push that blood into the pulmonary artery and the aorta, once that's complete, that pulmonic and that aortic valve, they will swing shut, and that's S2 sound. That'll be the dub, okay? So I've mentioned these atrioventricular valves, okay? So we've got the tricuspid valve, and then we've also got the mitral valve, and they are sometimes referred to, the mitral valve is sometimes called the bicuspid as well, okay? So they will shut at the beginning of ventricular contraction, okay? So once those ventricles have contracted and emptied their contents into the ventricles, they will swing shut. Because if they didn't, and then you had the ventricles contracting, you would get blood that's being pushed back into the atria and some blood that's going into like the pulmonary artery or the aorta, okay? It wouldn't make sense and you wouldn't get an effective pump going. So hopefully that makes sense a little bit. When these atrioventricular valves close, we call this the beginning of systole or the end of diastole, okay? And they will produce the lub of the lub-dub sound, which is also referred to as the S1 sound, okay? I thought I was really clever and I had this sound that I thought this little thing would click and play lub-dub, but it hasn't worked. So, but I've got it also, that audio within your course content. But also in our labs, we're going to be listening specifically for our lub-dub sounds or the S1 and S2 sounds. So come along to the labs and we will practice that with our stethoscopes, okay? So then when we move on to our semilunar valves, we've got two of those, and that refers to our pulmonic valve and our aortic valve, okay? So these valves will close after the ventricles have contracted and emptied, okay? And we refer to this as the end of systole and the start of diastole. So the end of contractions and the start of then that ventricle relaxing and filling, okay? So if you think in your mind, okay, if I've got a ventricle that's now filling with blood, if those valves were open, the blood would then sort of leak through those valves and it wouldn't be, again, it wouldn't be an effective pump action there, would it? So they need to be closed while that ventricle fills. That sound then, when those pulmonic and the aortic valves shut, that sound produces that dub of the lub-dub sound, or we call it S2. So those sounds, a really good way of thinking about it is each time you hear that lub-dub sound, I always think of it, it's the sound of those valves swinging shut. So thinking about like a closed door. So every time a door closes, it'll make a sound. Same as when those valves snap back or close. That's the sound that it's producing, okay? So we've been talking a lot about how the heart is a mechanical pump as such. It also has an electrical function, okay? And you can get a really good read of this electrical function or this electrical activity through an electrocardiogram, or we call it an ECG. You guys will learn about how to do this and how to interpret this sort of when you get into second year, but it's really good to be aware of it now and what ECGs help us do. So in my role in ED, I rely on ECGs quite a lot to tell me what is going on with my patient when they're presenting with sort of any type of symptoms that could be down to being of a cardiovascular cause, right? So stock standard, best evidence-based practice tells us that if a patient is presenting with chest pain, then we need to be doing a ECG within 10 minutes of them complaining to us and presenting with that chest pain, okay? Because then the main thing that we're wanting to rule out, so worst case scenario I want to rule out with that ECG is that my patient's not having a heart attack or a myocardial infarction, okay? How has this ECG tell me my patient's having a myocardial infarction? Through that electric activity, we can read damage to the heart muscle, okay? So, sorry, I always can't work my fingers out right here. So down here in this like lower waveline there, you can kind of see, instead of it being a nice up and down QRS complex, we've got a lot of ST, where's my finger? Right there. We've got a lot of ST elevation here, and also in our upper leads in sort of V1, 2, 3 really. This person is probably quite sick and they're definitely having a heart attack right now. So the whole purpose of this ECG when someone's complaining of a chest pain is we want to rule this scenario out, because if this is what I get back when I do an ECG quickly on a patient, then it's all action stations. We need to get this person commenced on treatment immediately. And most often for us in the hospital I work at, it means we take them to the cardiac cath lab, and that's when they go and get like a stent and resolve the blockage or try and treat the blockage that's causing this ECG. Other things that you can see on an ECG is if a patient's ever got an arrhythmia. So if people have got arrhythmias, sometimes that can then make them feel lightheaded, dizzy, short of breath. It can make them collapse. So this ECG, it can tell us a lot about our patient, and it's good just to understand that the heart, other than having a mechanical function, also has an electrical function, and so this is how we can pick up the electrical function of the heart, essentially, or this is how we can assess the electrical function of the heart. So when we're looking at our vasculature that's surrounding our heart, so we're thinking sort of our big, great vessels surrounding that heart, okay? So we've got our superior and inferior vena cava. So their role is to return deoxygenated blood to the right side of the heart. Then we've got the pulmonary artery. So it will leave the right ventricle and it'll carry that deoxygenated blood to the lungs to then get reoxygenated, okay? Then our pulmonary veins, it will return freshly oxygenated blood from the lungs to the left side of the heart. We've got that aorta, so that red, big, great vessel that's arching over there. So it arches back at the level of the sternal angle and descends behind the heart. So it's a really, really big vessel. It's a very, very important vessel, and it can contain a lot of, or withstand, sorry, a lot of pressure, because that left ventricle, it's big, and because it's got a really big role in pumping like a huge amount of oxygenated blood to the rest of the body. So it needs a vessel that's going to be able to withstand that initial really high pressure. Then we have got some additional vasculature that relates to our neck vessels, and but they're still quite close to the heart, so that's why we include them here. So we've got our jugular vein. So its role is to basically return or drain deoxygenated blood from the head and the neck back to the heart. We'll discuss this more in our physical examination of our patient. And within the carotid arteries, they carry oxygenated blood to the head and neck. And we'll discuss that in the physical examination as well. But you can imagine or understand that the carotid arteries and our jugular veins, they're two really important vessels as well, because they're vital in providing our brain with oxygen or an oxygenated blood. And if that doesn't happen, you will see big symptoms and big side effects of that from our patient. So when we're looking at our peripheral vascular system, so I've mentioned that it will refer to arteries and veins of our limbs, so our arms and legs. Its job is to transport blood to and from the peripheries, okay? And it's vital for adequate perfusion. When someone's unwell, that's when you see that peripheral vascular system becomes compromised, because your heart or your body understands that it's compromised, so its role that they want to preserve the good oxygenated blood for the heart and the head. And so that's when, if someone's really unwell, and particularly in pediatrics we do it, if I can see that they're peripherally shut down, so I can see they haven't got good circulation in their fingers and toes, or their arms and their legs, in my mind, I start to think, right, they're not well, they're maintaining as much of their good blood or their oxygenated blood for their central core and like their vital organs that are within this central core and to their head, okay? With lymphatics, so it's a separate vessel system, which I sort of mentioned how it will retrieve excess fluid from our tissues that's escaped from the capillaries, and it will return to the bloodstream. So fluid will often leak through the capillaries, but as long as we've got an effective lymphatic system in place, it will then retrieve that excess fluid and return it back into our great vessels. So where you can see that doesn't work effectively is, and you guys probably have seen this out and about in the community, you might sometimes see someone will actually be wearing like a tight sort of compression stocking on their arm. So particularly after people who've had a mastectomy and they have what we call an axilla clearance. So we've all got a lymph node in under our armpits. Sometimes with a mastectomy, if they think that there's sort of cancer involvement in that lymph node, they'll remove that lymph node. And now all of a sudden, you haven't got a good or effective, normal functioning lymphatic system in that arm, right? And so that person will often have to take very good care of that arm because, and then when it's becoming very compromised, you'll see someone's arm will become quite swollen or edematous, and that'll be because there's all this excess fluid sitting in there that hasn't been returned back into our bloodstream or into, like, you know, back into our arteries and veins. So when we're looking at our when we're looking at our arteries, so, and we'll go through pulses within the labs as well, but our arteries will, within our peripheries, they will deliver oxygenated blood all the way to the fingertips and all the way down from your legs until your feet, okay? And we've got some really good pulse points that we can assess on our person to make sure that the arteries aren't compromised and that they're working effectively. And so two pulse points that you guys have already learned how to measure in our labs now is our brachial artery and our radial artery. So on your patient, if you're not feeling a good pulse and you've confirmed it with someone else that you can't feel a good pulse, then you've got to think, okay, is there system compromised here? What's going on with our arteries? And there's other things that can help you assess whether this patient has got, whether it's been compromised or whether you have got good circulation going there. So if your hand is nice and warm and pink and perfused, good capillary refill, so when I like pinch my finger, it should blanch white and then return to a pink colour within like 2 to 3 seconds. If that's not happening and I've got a cold hand and when I pinch my finger it's taking like 5 seconds to return, I've got to think, okay, what's going on here? There's some compromise to this system. And you can often see this in people who've had surgery to their arms and their legs, or if they've got like a clot or an embolism there. But yeah, their role is basically to carry oxygenated blood to the tissues. And likewise, our veins. So we've got veins that will go all the way down our arms and all the way down our legs. And their primary role is to return deoxygenated blood to the heart. And they operate at quite a lower pressure compared to the arteries, okay? And I think we've all remember, hopefully, that veins will also have used valves within the veins to help prevent backflow and help try and push that blood back to the heart, okay? So within our lymphatic system, so we've got lymph vessels, we've got lymph ducts, we've got lymph nodes, and it plays a really important role not only in circulation and, you know, retrieving that excess fluid, but also within immunity. So from a circulation standpoint, so blood is transported to the sort of systemic capillaries where plasma and other substances are filtered from the capillaries. And then that sort of plasma that's not reabsorbed into the blood vessels, it becomes an interstitial fluid that is then transported back to the heart as lymph via the lymphatic vessels. Along the way, that fluid is then filtered by the lymphatic nodes. So you can kind of sort of understand that this lymphatic system plays a really important role in draining the tissues of that excess fluid and returning it to the cardiovascular system, because otherwise you'd have a person that's really swollen, really edematous, okay? We've got lymph nodes everywhere through our body. So we've got some like cervical lymph nodes, and they drain the fluid from our head and our neck. We've got axilla lymph nodes, so they will drain fluid from the upper arm and around the breast area. We've got our epitrochlear node, and that's in our like cubital fossa. Where's my arm? I move over here. We've got a, and often you can palpate that one as well, and it drains basically fluid from the hand and the lower arm. We've got our inguinal nodes, so within our groin, I know you guys, like, probably if you've ever felt really unwell and the doctor's felt under your neck, also if you feel really unwell, people can have quite enlarged nodes in their groin as well. And they drain most of the excess fluid from the lower extremities, the external genitalia, and the anterior sort of abdominal wall. So when that infection is present, those lymph nodes will become enlarged, okay? And they can sometimes become quite painful as well. And those superficial nodes, so those ones that I was mentioning there around your neck and your groin, and even sometimes your epitrochlear node, they can become quite palpable. I mean, you can really feel them or palpate them.